Good afternoon, and welcome back to HealthLeaders The Winning Edge program, a weekly series of webinars touching on topics and strategies that you need to know most. My name is Chris Cheney. I am the CMO editor for HealthLeaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Handling the APP Boom. Thank you to our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our panelists for today's discussion. Teresa Collin Glazer, Executive Vice President and Chief Clinical Officer at Ohio Health. Unfortunately, we can't get her webcam going for technical reasons, so she's going to be joining us just via her phone line. Deborah Fournier, Chief Advanced Practice Provider Officer at Dartmouth Health, and Reed Pierce, MD, Chief Medical Officer at Denver Health. Thank you all for joining us today. And with that, let's get into our discussion. Before we get into the discussion, first, please tell us a little bit about yourself and your organization. And Terry, why don't you go first?
Okay, thank you. And again, sorry I can't be on webcam here. But I am a cardiologist by training. I've been with Ohio Health for 23 years. We are a health system in Ohio, based centrally in Columbus and then extending into the region. We have 16 hospitals, several rehab hospitals, and over 300 practices.
Deborah?
Hi there. I'm Deb Fournier. I am a nurse practitioner. I'm boarded both actually in medicine and in psychiatry. And Dartmouth Health is an academic medical system that covers our catchment areas, Vermont and New Hampshire. We have several hospitals and more than 30 clinics.
Great. Reed?
Good morning, everyone. Afternoon, I guess, for some. Thank you all for joining us. My name is Reed Pierce. I'm an internal medicine physician. I'm the Chief Medical Officer at Denver Health, which is the largest safety net system in the state of Colorado. We serve primarily Denver city and county, but also take care of folks in the safety net across the state. We're a single hospital system. We have 10 federally qualified community health centers out in communities around the Denver area. We have about half of our medical staff now consisting of advanced practice providers, which has been an area of great growth for us over the last 10 to 15 years.
Excellent. Let's get into our discussion. What is the optimal role for APPs in providing team-based care? And Terry, why don't you go first?
Okay, well, as a large healthcare organization, 40% of our providers are APPs, and we use them in multiple areas from inpatient to outpatient. So for primary care, they're involved in managing their own panel of patients. They do chronic disease follow-up, routine visits, preventative screenings. In specialty and acute care in our inpatient settings, They are involved in a lot of our specialty service lines like heart and vascular surgery, some of the specialty surgery, as well as critical care. And they are a large part of contributing to our patient throughput and decreasing the average length of stay, just to mention a couple of the areas where we do use them.
Deb?
Sure, thanks. So again, as a large rural health system, we have APPs at every site in every specialty. We also have APPs who do provide primary care. They are the primary PCPs for many folks, especially in the more rural areas of our system, managing their own panels independently. New Hampshire is a state where both PAs and both physician associates and nurse practitioners have full practice authority. So they are able to practice independently, both in the specialty and the primary care settings, and also cover many of our inpatient teams. We have almost 900 APPs now, and in some of our hospitals, they are the majority of our provider staff. At the academic medical center, we're about 40%.
And Reed?
I think the answer is similar for Denver Health. We have APPs embedded in literally every part of our care delivery system, from primary care to specialty care to surgical care, both in the hospital and out in community. You had asked, Chris, about what role on the team can APPs play. And I would offer, in addition to being a direct provider of care, whether it's in primary care, specialty care, or surgical care, many of our APPs have taken on formal and informal roles being team leaders. Some of that may be around coordination. For example, in our inpatient infectious disease team, a lot of the daily work in the organization of who is going to see which patient happens through the APPs on that service. In other instances, we have lead APPs who are helping to build the schedule, do onboarding and orientation, lead quality improvement efforts throughout the care delivery system. So there's a leadership component above and beyond the clinical care that we found to be very important and very impactful.
Excellent. And that's a good lead in to the next question, which is, are there circumstances where APPs can lead care teams? And Deb, why don't you start us out?
Sure. So the answer to that is absolutely. And as Reed just described, we also have recognized the expertise and the education, the talent of our APPs really lends well to leadership roles, both in the clinical spaces where we have APPs leading clinical teams of other APPs, but also in roles in quality improvement, in finance, and even in the inpatient setting. We have one group where we have psychiatric nurse practitioners serving as leaders of the interdisciplinary care team and have created a culture and a training model that really supports them in doing that effectively, such that patients and community partners recognize that in this particular hospital, that there's actually more of a chance that a patient's care will be led by an APP than a physician.
And Reed?
In addition to the clinical areas and domains that we've talked about, I'll add a couple of others. One is in the governance space. So for many, many years at Denver Health, we had a process whereby most of the things that happen with the medical staff happened through committees that were led by physicians. And increasingly, we've shifted to say we need to have active membership seats for our APPs to sit on our medical staff executive committee. And we need to have positions that are directly related to the experience, the work experience of our APPs. So we've now created an APP council that is co-chaired by two of our APPs. So that's been an important leadership journey, both in terms of being able to hear from our APP workforce, focus on issues that are important and sometimes unique, but also making sure that APP leaders feel integrated. Separate from the governance piece, many of our APPs are also what I'll call clinical innovators. So we've had a number of instances where the spark or the idea for a new clinical service line or integrating several services into one place was led by one of our APPs. As a safety net institution, one thing that comes up for us fairly often is some patients come to the hospital, they don't have the social and the economic and the sort of peer resources to take care of themselves easily outside of the hospital. They get stuck in the hospital and they have very long length of stay. We have a dedicated unit that is more home-like, that helps people feel less like they're in the hospital and more like they're preparing for discharge for folks who may be there for multiple months. That whole initiative was led by one of our nurse practitioners who said, there's a need. This is something that I can help to do, not only clinically, but I can build the model, can make the case, and can grow the service line, which has been fun to watch.
And Terry?
Okay, well, in addition to what my colleagues have reviewed, some of the other areas where we use them at Ohio Health are one in leading our care coordination and communication team. So our lead APPs really coordinate the disciplines around nursing, pharmacy, case management so that there's a cohesive discharge planning and coordination and update with the families. And they follow through after discharge. In addition, they're heavily involved in our HRO journey. So we're on a journey to be a high reliability organization. So they have taken leadership roles in quality and safety, specifically around some of the projects that we have for infection control, pain management, and then patient satisfaction and service quality to the patients. So they actually are the consistent leadership in those areas, and they do that not only in the local area, but they have system accountability across the hospitals.
And a follow-up question, what qualities do you look for in an advanced practice provider to play a leadership role on a care team? And Reed, why don't you start us off?
The answer here for me is the same as it is for any of our clinicians who want to do leadership in addition to their clinical role. It's very important first to be excellent in your area of clinical practice. I think credibility, people seeing those of us who are clinical leaders as a member of the care team and able to be expert clinicians, that is still very important in all of healthcare. But second and third, the ability to communicate and to bring people together, I think, are really important pieces of the puzzle. So often when folks step into leadership roles, there's a bit of a shift from being the expert in my area to I'm trying to work with a team of experts to solve an intersectional problem or to work together to make the system optimized. That requires a lot of good communication, and it requires, number three, the ability to convene the right stakeholders to be in the conversation about what are we working on. How do we do that and why? So people who have that relationship orientation are particularly successful in my experience when they step into these clinical leadership roles.
And Terry?
Yeah, so at our organization, we look at high potential individuals. And again, this would be for all of our providers. So in terms of the categories, we look at ability. So are they a consistent high performer? Do they have system agility, and have they shown that they've had formative roles, experiences, or development challenges that they've been successful at? I look at versatility, so, curiosity, broad interest in the scope of the role, a high capacity for work and leading people. Also, it's aspiration. Do they have the desire, the motivation, and the attention to be leading a team and to work at a leadership level? And then the third area I look at is engagement. So how well do they engage stakeholders? What is their level of influencing and communicating a project or a process or a vision that we're working towards? And are they able to be change agents? So those are the things that I would be looking for in any leader. So it would apply to our APPs.
And Deb?
Sure. If I could just add that I think that when we're looking at, again, for any leadership role, collaboration is key. In addition to the communication, we need that curiosity to come through. For when I think specifically about advanced practice providers being in leadership roles, in some cases, APPs, there are many APPs who may not have seen themselves in a leadership role. So having the ability to recognize that talent, to reflect that, and then to mentor folks into those positions, I think is really important and something that we need to pay attention to for their professional development and to build their efficacy as a leader. APPs have really been a discipline that fills some of the spaces in between other disciplines. And so I think that their education, their work experience, as well as their clinical expertise really positions them well for many different leadership roles.
Excellent. What is the optimal role for APPs on inpatient care teams? And Terry, why don't you go first?
So I think for the APP and an inpatient, there are multiple roles, and then they're critical roles, both as leading teams and being part of teams. So it's daily patient management. They're involved in daily rounds, the progress notes, managing orders for the patients. Their role is really to maintain the continuity of care and making sure that the transitions of care are going smoothly. They're involved with the admission of patients as well as the discharge, and that is extremely important for us in terms of our throughput in the hospitals. And we find that teams that we have our APPs embedded in, the throughput and length of stay is shortened when we have APPs leading or on our teams. They work in our critical care in terms of ICU management. So they'll work with the intensivist in terms of, ventilators, medication, emergencies. If the intensivist is off the floor, they're involved with, managing the patient and family communications. They are incredibly important in all of our procedural areas. So we have APPs that are trained in procedures. So they will be doing central lines, LPs, things like that. And then again, they're really important in our discharge management. So I would say that our transitions of care and our handoffs, they play a critical role on. And we've looked at this, and our length of stay really in our ICU units as well in the hospital are really improved with our APP involvement.
Deb?
Sure. So I think when I think about the ideal role for APPs, I keep coming back to this thought about it's no different from the ideal role we would want for any discipline. We want APPs to be recognized for the value, expertise, and experience that they bring to the team, just as we would for other disciplines. And as Terry said, we fill lots of those needs on many different care teams. We have APPs who provide just daytime coverage. We also have APPs on teams that provide 24/7 care and serve in consulting roles. So we have APPs who really have become known as experts in their field in the inpatient setting, and they are the ones to respond to consults occasionally. I think that the services continue to grow and recognize this value that they bring to the team. I think that one of the other things that's important, though, as we build these teams, is to recognize that it's different from resident coverage, that APPs really do bring unique value. And at an academic medical center, we also are faculty. And so another important role for our APPs on the service is to be involved in teaching trainees of all of the disciplines and really modeling how to practice and educate in an interprofessional way.
And Reed.
I don't have a lot of new things to add. I think we've touched on many themes that are true for us at Denver Health. I'll add two other components. One is not only for our learners, we're also a teaching institution for many different health professions, but also for our new employees. Often our APPs are in a great position to coach, teach, and be the keepers of knowledge that makes onboarding faster for a whole bunch of new clinicians because of that continuity piece, the expertise piece, and the fact that they really understand both process and the nuances of how care happens in a hospital. The other thing many of our hospital-based APPs do is they are frequently the strongest bridge back to many of our specialty clinics. So while our surgeons, for example, spend time in both clinic and the hospital, so often it's our APPs who are helping the work happen on the front end if we're scheduling surgery, and then making sure that we've got good follow-up in the clinic. And the APPs who may have been present in surgery are also in the clinic helping to support that post-op care with a greater degree of continuity than some of our specialty clinicians and physicians.
Excellent. And this is kind of the sister question. What is the optimal role for APPs in outpatient and specialty clinics? And Deb, why don't you go first?
Sure. I think we've touched on how APPs can serve a really important role in providing primary care services, especially in our more rural settings. In outpatient clinics, we have a few different models, and Reed mentioned this, how important it is for APPs to, in the surgical specialties, to sometimes be the ones to do the preoperative care, to, and in some cases, assist in the OR and also round in the inpatient space, providing really critical continuity. We see high levels of patient experience scores, high patient satisfaction, and really strong patient outcomes when we have that kind of continuity of the APP provider throughout the different settings in the care teams. We also have many APPs who have developed a lot of expertise in some of our subspecialty spaces. So, for example, in our Center for Digestive Health, it's our APPs who provide most of the outpatient care in liver disease, in motility disorders. And it also helps to support our some of our physician colleagues to be doing more procedures and back in the OR.
Reed?
We use APPs throughout our specialty care services at Denver Health, and very often there is an opportunity to really come back to that team lead concept in the clinic setting. So often our APPs are helping to be the coordinators of the action in the clinic alongside their partners who may be in a nursing role and the physician medical directors. That has been particularly important not only in clinical care and in the kind of continuity and coordination we've been talking about, but when it comes to clinic-based specialty quality improvement projects, very often APPs are the clinical experts that will be around the table with our lean team, with our IT team, helping to figure out if we're going to change a scheduling template, if we're going to change the way that flow happens in the clinic, how do we make that work? And it's a great opportunity for their leadership as systems improvers to be a key part of making specialty clinics run well above and beyond clinical expertise.
Terry?
Yeah, so in addition to what Deb and Reed have reviewed, I'm going to highlight two specialty clinics where we really have our APPs working in a very independent but collaborative way with the specialists. So the first is in heart and vascular in our AFib clinics. All new referrals are actually seen by the APPs, and these referrals are all evaluated for whether they have been treated as they were referred into the clinic with evidence-based protocol standards of care. They go through this. If the patients fail first or second line treatments, then they'll get pushed into the physician clinics where likely they're then going to be going on for a procedure. But this frees up the physicians for maybe a higher acuity case or to be in the procedural lab. Similarly, in our spine surgery ambulatory clinic is the model where all new patients are first evaluated by the APPs. They screen out those that are not appropriate for surgery and follow evidence-based medical protocols for their care. And then when that's failed, then they're referred on to the surgeon for care. So those are two areas in specialty where they really are frontline providers and evaluators of new patients.
And I'm interested, because all of you talked about primary care, as a kind of a hotbed for APPs. I'm wondering if each of you can go into more detail about how APPs are functioning in primary clinics at your institutions. And Reed, why don't you go first?
So if we go way back to the start of training APPs in the United States, we're now going back in history 50 to 70 years. Part of the original idea was that APPs would really be a core component of the primary care workforce, and we're positioned and trained to do that work. So we've had APPs in primary care for a long time at Denver Health. They play a number of different roles. So many of them, as we've already touched on, are individual primary care providers. They have a panel of patients, they manage those patients, and they are primarily responsible for the health and well-being of patients who are assigned to them. Many of them also in primary care bring a focused area of expertise. So to bring a different example, we have in our federally qualified health centers embedded integrated behavioral health. And those APPs are in essence a behavioral health specialist in primary care who can see a patient that day. Those APPs manage their own small panels sometimes, but more often it's like being available as an internal consultant so that somebody who comes into primary care with a behavioral health need can get the services they need that day or in short order at the same clinic. The third thing that our APPs in primary care often are engaged in is a variety of telehealth services. So some of our patients may find it hard to come into the clinic. We are out in community, but still it's easy to meet people where they are, and very often they're on their phones or their devices. That by extension has been a really cool opportunity that is somewhat unique to Denver Health. We a number of years ago said, if we positioned a small clinic in our high schools as an extension of primary care, we could probably meet teenagers in a place where they would be more likely to come in and talk about their behavioral health needs, their other health needs, as opposed to having them schedule an appointment at the clinic down the street. So some of our APPs are either doing telehealth visits into the high schools or at times are on site at the high schools to be an extension of primary care in that space. And there's been both huge demand for those services and a lot of really great outcomes for our public schools who have been excellent partners in helping to run that program.
Terry?
Yeah, so again, as Reed said, they manage in our outpatient primary care area their own patient panels. They are involved in care coordination and continuity in the primary care clinic. So, as a consistent touch point for patients with engagement and adherence. They lead the quality improvement. We have a lot of ambulatory quality initiatives that they participate in the clinical governance and management of those projects. We have school-based clinics, as Reed mentioned. The other area where we consider it primary care because it is essentially a front door and they are essential for is urgent care. And so many of our urgent cares are managed and run by our APPs.
And Deborah.
Sure. Much like my colleagues have shared about the way that APPs are in the primary care setting, we've been investing some time and energy in really looking at this, that while it is important for our APPs to exercise their independence as primary care providers, we're recognizing that there are some challenges in the training and opportunity to develop that expertise so folks can manage those panels independently. And we have been looking at a couple of different team models where APPs newer in their career and their practice may be partnering with a more experienced APP or a physician colleague to collaborate on some more complex issues, as well as develop these areas of subspecialty expertise, whether in chronic disease management or another particular diagnosis. So really looking at how we create the model that provides the best patient care and generates the satisfaction and sustainability for our APPs, and looking at things like what's the right panel size and what are the right work hour expectations, as well as the triaging that may need to happen to have folks be seen by the right provider at the right time.
And go into more detail about the training that you're providing for your APPs in the primary care setting.
Sure. So this is really important in an area that we need to focus on, that we are seeing so much more variation in the ability for new graduates from APP programs to successfully make a transition into that practice role, into that professional role. And primary care, as we all know, is the space where you have to know a little bit about everything and be good at that and triage what needs to be escalated, what needs to be referred. And that's a lot to ask for a new graduate. So we're taking a couple of different approaches. We are investing in increasing our capacity for the quality of pre-licensure clinical training. So working with our current APPs who are more experienced in primary care to be clinical preceptors for some of our academic partners in the region. And then investing a lot in our onboarding strategy. So we are creating a manualized, more standard approach to reaching out to provide that support for onboarding providers, new providers into primary care. That includes recognition of where the knowledge gaps are in their education, providing an education series targeted at those most common gaps, and creating space for a dedicated mentor who can assess competency at specific milestones to be flexible in that ramp-up space. And then looking for where are the areas that we really need a more structured postgraduate fellowship, and primary care may be one of those places where we see some growth in the fellowship space to give APP new graduates dedicated time of about a year where they are really engaged in additional didactic and educational support as they're learning the profession to be successful in the primary care practice.
And another thing you mentioned, Deb, is having the right panel size for APPs in the primary care setting. How have you determined that?
Great question. So that remains to be seen, but what we are looking at is the balance of patient experience scores, patient satisfaction scores, staff engagement, staff experience, staff burnout, and matching that with panel size or visits per day. So it's a work in progress for sure, but we're starting to get some really promising results that'll help guide our practice moving forward.
Great. And this is something I'm really interested in because of because APPs are becoming more important members of care teams. How do you balance support versus supervision in the APP physician relationship? And Terry, why don't you go first?
Sure, because I think you're right, this is a really important area, and you do want that onboarding and integration into the team and the relationship between physician and APP to be strong and respectful from the beginning. And one of the things we do is we really try to be very clear about defining roles. So in our institution, we've got protocols that outline responsibilities, decision-making authority, and escalation pathways so that everybody is aligned and understanding what the process is. The next thing we do is we really work with our new APPs. Our whole goal is for them to be successful, to feel like they're part of a team. And in order to do that, our new APPs, as Deb was saying, they need to be onboarded correctly. So making sure that for the first 3 to 6 months, they have the appropriate oversight with a seasoned provider until they feel like they feel more comfortable working independently. And then it's a tiered model of monthly, then quarterly, then semi-annual check-ins to make sure that they're progressing and that they feel like they're actually being able to live up to the top of their license in the terms of the work that they're doing. So those are some of the things we do just to really focus on role clarity, appropriate support and supervision as they're onboarding, and then regularly scheduled check-ins to make sure that they're progressing and they feel like they're being able to work to the top of their license.
And Deb.
Sure. I think that the key word again is collaboration, that if we have APPs and physicians who can collaborate with each other, recognize each other's strengths, leverage the differences in their training and their expertise, then they will become an effective team. We have a particularly strong example of this in our orthopedics team, where we have an orthopedic surgeon who has spent a lot of time investing in what works and what doesn't work in her relationship with her APP colleagues, and really speaks to how important it is that that relationship be flexible, that it evolve in response to the APP's skills, strengths, and ability to be independent. And one of the key features to the success of that relationship is the education that the surgeon and the APP do of their colleagues and of their patients in what strengths each of them bring to the team. And almost as if there's like this transfer of confidence where the physician will say to the patient and to the colleagues, I will see you in the OR for your post-operative care. The APP really is the expert in this space, and I'm very confident that they will manage things for you after that OR visit. So really recognizing that role definition, the expectations, and leveraging the strengths that each role brings to the relationship.
Reed?
I think we've touched on a lot of really good nuggets related to this topic. I'll add a couple. One, this piece about expectations, I think, is particularly important. And sometimes those expectations are embedded in an onboarding process with formal check-ins. Often, though, this is a place where organizations are responsible, and this is work we've tried to do at Denver Health, to say to the clinical leader, whether it's the medical director, the division chief, the department chair, this is something you need to be very clear about with the physicians and the APPs who work in your area. There may be a little bit of variation depending on specialty. So for example, just as Deb said, if APPs are going to spend time in the operating room, they may be under direct supervision the entire time working side by side with the surgeon, but then in the surgical clinic, APPs are practicing almost entirely independently, touching base as needed with the physician. That goes much better if there's a collective discussion like we've been referencing and expectations are clear and are shared. The other piece that I think is helpful to pay attention to, this is one that I still feel us working out across the country. It's been challenging in every organization I've worked in across my career. We still don't have a lot of places in which residents and fellows, so future physicians in practice, are working alongside APPs, either in their daily work or APPs in training. And so frequently we still have physicians who graduate and they join our workforce, and they may not have worked with APPs that often, and they're not quite sure, what is this balance? Should I talk to my APP like it's a first-year resident? That doesn't go well. Should I simply assume the APP doesn't need any supervision? That may also not go well because the APP may want to run cases by the attending. And so having embedded in the physician onboarding some prompts and some conversation around what does this look like if you haven't been in a practice environment where you've worked with APPs often, that's a gap that we still frequently need to close in our organizations.
Now, we've talked a bit about onboarding. First, I'd like to focus on APP onboarding. What are the primary elements of a good onboarding program for APPs? And Deb, why don't you start first?
Sure. So I think the first step is to lay the expectations of advanced practice for the organization in a standardized way. I think the next step is to recognize where there are common knowledge gaps. And we provide some additional education series to fill in those gaps that we've seen most commonly come up for new graduates in particular. And then creating that mentorship relationship that I mentioned is really important, so that there is someone who can assess the competency and the progress in an onboarding strategy and be that point person for an APP. in that process. And then the connection with the rest of the APP teams and the APP practice throughout the system, I think, is the final key component to the onboarding strategy.
Great. Reed, you want to go next?
I'll build on that theme of expectations. And some of this gets to Deb's comments earlier about in which instances are we thinking about onboarding, which may be a couple of days, it may be 2 weeks, it may be 4 weeks. In which cases are we thinking about a more prolonged orientation, the longest version of which I would call a fellowship, 6 to 12 months, where you have very progressive graduated milestones. In both of those systems, I think having real clarity about what are those specific milestones through which a person is going to grow, how many visits in clinic or how many patients in the operating room, which patients get reviewed with the physician, which charts need to be co-signed, and at what point do those things change. If you have that down on paper, it tends to go much better as opposed to show up in the environment, someone will be available to you for some period of time, and we trust that you're just going to figure it out. So I think the more clarity that individual teams can have around the expectations, the better. And that's going to vary depending on the care delivery environment. What that looks like in a primary care clinic as opposed to an ICU varies quite a bit. The other piece that I'll offer is that APPs, unlike many of our physicians, often are in a position, particularly if you're a physician assistant or a nurse practitioner, to move laterally across specialties. So it's not uncommon for someone, for example, who has worked with the GI team to at some point say, I'd be interested in being a hospital medicine APP. Those people tend to come with great depth, experience, and expertise in a subset of domains, but they may need reorientation around some of the fundamentals in that new specialty or practice area. Whereas often for our physicians, you don't often have a gastroenterologist who changes to become a hospitalist. And so having some prompts at the front end of the onboarding process, if somebody's changing specialty, to say, where do you feel strong? Where do you feel particularly competent? Are there areas where we may need to take a step back and take more time to reintroduce you to some of the core knowledge and the core practices in this new environment? That's also a key piece that we have to pay attention to.
Terry?
Yeah, so our onboarding is a little bit different. So I'm just going to spend a little bit of time here because I do think it's important. We have, for the first week of employment of all of our new providers, so physicians and APPs, they undergo a system onboarding for the first week. So they are side by side for a week at this meeting, for this onboarding. And so they are all in the same room, hearing the same message about the Ohio Health values, our missions, the goals, and our expectations of how our providers will be working. During that time, we spend a great deal going into team-based care and the right person seeing the patient at the right time in their healthcare journey. This includes nursing and pharmacy, but we want our APPs and physicians to know they're onboarding as a team for the organization, and that the only way they're really going to be meeting our goals is through their approach to team-based care. After that week of orientation, which is, going through all of the basics for Ohio Health, they do their EMR training together, so all of the things that they need to onboard for the organization before they ever go off to their individual campuses, where then they'll do their onboarding for their specific area in the hospital. But I think that front part is really important because it sets the expectation of how you will work at Ohio Health.
Great. So we just went over successful models for APP onboarding and orientation. What professional development opportunities have you considered for APPs? And Deb, why don't you go first?
Sure, thanks. So this is another area where we have really committed some time and resources. When we look at the attrition data for our organization, in addition to, it really mirrors what we're seeing nationally, that we see folks, APPs, leave their jobs or resign from their positions at the highest percentage in the first 3 years. And that's why we've invested in the onboarding and transition to practice efforts we were talking about earlier. But the next bump in attrition that we see are in our APPs that are 10 to 12 years into practice. And that is consistently about a lack of professional development opportunities. So we're incredibly committed to improving this in our system. We've talked about different leadership roles earlier around leading APPs leading other clinical APPs being in other leadership positions throughout the organization, and really expanding our thinking about what that looks like. That we have now a couple of positions in our system that are medical director roles or directors of ambulatory services, where APPs are absolutely eligible for and encouraged to work towards and to fulfill those roles. We also have a growing number of APPs integrated into our governance and decision-making models. As Reed was describing earlier, we've also have a really strong history in APP representation in what was our Board of Governors and is now referred to as our Group Practice Council, where we have equal representation of APPs and physicians really guiding key decisions in our clinical practice throughout the health system. And now also we are having APPs become more engaged in key committees like Board of Trustees, associated committees. So thinking about clinical leadership, thinking about operational leadership, and thinking about other opportunities in governance, I think is really going to make a difference for us. We also are investing in how we can help with academic or educational professional development opportunities, how we increase, support folks to increase their educational skills, as well as work towards faculty promotion. And our investment and strategy around interprofessional education provides some really great opportunities for that. I love the idea of the 1 week training for the interprofessional teams in onboarding. I really like that. And we're doing similar things in our education and faculty models. It's really exciting.
Reed?
I think Deb covered the themes that I think about a lot very, very well. I'll add a little additional information around the data that we've pulled. We've looked at turnover and attrition data. We've looked at, in addition, burnout and well-being data across our organization. And one of the interesting signals that shows up both for physicians, but even more strongly for APPs, is if people answer no to the question, do you have a career mentor, their burnout rates are significantly higher. And the prediction of turnover is also much higher. And so one of the things that we've been working on, this was initiated by our APP Council, is building a peer mentorship training program. Because what we were hearing is, while folks may come to a job and say, I know who my clinical mentor is, someone I go to if I have a question about a clinical case, I also want someone I can talk to periodically about where am I in my career, how am I balancing work and life, what's important to me, are my career interests and my development needs shifting, who is a safe space, a good listener, and a sounding board. And so we've started to develop a program where we're trying to spread that set of skills to more than just our leaders, because we recognize that each APP lead is suddenly saying, I have to also be the mentor for 10, 20, 40 people. That system doesn't scale. So how do we embed more of that mentorship, career mentorship, for all of our APPs? We think that's going to be an important thing to address for burnout and for retention.
Terry?
Yeah, so again, support what both Deb and Reed have reviewed. So we do encourage and provide stipends for clinical specialization and certification. So whether it be in our cancer program, cardiology, or critical care. So we do have stipends and encourage our APPs along that line. We have a provider leadership development course that we run through the organization. Through that, they learn leadership competencies such as crucial conversation. They're introduced to strategic planning, to the basics and fundamentals of finance and team management, so that as they're being involved in projects that may be actually outside of their clinical work that they have the administrative knowledge to be able to participate and look at that leadership ladder also. We also have gradations of leadership training within the organization called Lead, Excel, and then the final one is Crossroads, where we partner with other healthcare institutions and we basically have peer swapping. So people get exposure to other health systems and how they work, and they bring that knowledge back to their own institution. So again, I think you want to invest in the talent because, the pool is shrinking, retention is important, and you've got to invest in your people.
And give me another example of how you're investing in your talent when it comes to APPs, Terry.
So I would say specifically it's the three areas. One, if they want more advanced clinical certification and training, we pay for that. So, we encourage it and provide the financial support to be able to do it. For leadership development internally, we have a leadership course which really addresses all the fundamentals of leadership, which is strategy, it's financial, it's team building and management, and how you end up having crucial conversations, all of the things that they will be exposed to. We start involving our APPs in work outside of clinical areas. So their network within the organization is growing, and other leaders are being able to see their leadership skills, not only their clinical skills. And then finally, within the organization, we have very structured, tiered leadership courses that are called Lead, Excel, and then the Crossroads, which is the exchange with other health systems.
Great. I think we should probably switch over to Q&A. We're down to about 9 minutes in this program. First of all, I want to thank you all for an excellent discussion. This now brings us to the Q&A portion of the program. So we would now like to invite you in the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. While we wait for some questions to come in, I'd like to start off by asking each of you, what are a couple of key takeaways that you would like the audience to take from this discussion? And Reed, why don't you start us off?
I think we've covered a lot of great topics and important ground, Chris. I'll elevate two. One, this idea of providing rigorous, structured onboarding, I think has really resonated with me, both from our conversation today and in my experience. There can be a temptation in health systems to look around and say, we're struggling with staffing, there are gaps in the schedule, let's hire an APP to help, and let's put that person on the schedule as quickly as possible. And then so often people burn out, they get frustrated, they leave the organization. If we take the time on the front end to do this right, people tend to stay, and they tend to be much more satisfied in their work. So the onboarding piece is one that I would elevate. The second is this concept of leadership that I think for a long time, much of the national narrative has been about the important clinical roles that APPs can play and that they're part of the clinical workforce. We've heard lots of examples in which APPs are critical and in some cases the best leaders for certain initiatives in our health systems. So really elevating that pathway, both so that people have a chance to grow, but also so that we can improve care in the way we've been talking about today.
Terry?
Yes, I agree. I mean, I think onboarding is really important. I mean, for me, the most important message is that the best APP physician relationship is a partnership. The role of the physician and the APP has to be grounded in shared goals, adaptive structures based on, the programs that you're building, and mutual accountability. And that deep-seated respect for the strength and the knowledge and the competency each is bringing to the patient.
And actually go into that mutual accountability. I mean, that can be a touchy subject between any pair of staff members. But with the evolving role of APPs, I imagine it's even more touchy between APPs and physicians. How do you have that mutual sense of mutual accountability, Terry?
So that's where I would go back to the onboarding. The onboarding is key because that week of spending time together as new associates in an organization sets the culture in which we expect everybody to work. So the physicians are hearing the same message as the APPs, and we're talking about building a team from day one as you enter the organization, and that is a mutual accountability.
Great. Deborah, what are your key takeaways?
I think one of the things that we have all really felt strongly about is how important it is as organizational leaders to invest in this part of our workforce, to recognize the strengths they bring to patient care and to our clinical teams, and really continue to challenge ourselves in coming up with how we redesign how we're delivering care, being open to how we leverage the strengths of APP education and training. And we've talked about a lot of different leadership and professional development opportunities. And I just want to emphasize the importance of that representation and engagement and governance. More and more organizations are having APPs serve in roles of vice president or chief officers. And it really makes a difference in the engagement of the entire APP workforce.
Great. We have a question here. Do any of you have experience with APPs being voting members of medical staff committees? And was there pushback from physicians in the organization? Anybody want to tackle that?
I'm happy to start. Oh, go ahead, Deb.
Sure. So at Dartmouth Hitchcock Medical Center, we've been voting members. The APPs have been voting members of the medical staff for more than a decade. And it really has been a conversation about just engaging each other around the contribution that we're making to the clinical footprint. And when there's recognition of the work that APPs do, the way that we are contributing to the clinical care of the organization, then I would say that there's not pushback. There's really openness and engagement, people being curious about what is a medical staff really responsible for. It's the oversight of the delivery of high quality clinical care, and APPs are a large part of that.
And Reed, I think you wanted to jump in on this one.
Yeah, I agree with Deb. This is important for reasons of representation and also to make sure we have the best information and input about what the clinical workforce, particularly the medical staff workforce, needs to be working on. Similarly, at Denver Health, for many years, we've had seats on our medical staff executive committee that are dedicated to APPs. About half of our workforce is APPs. And so I think part of the making the case over time journey has been, if half of our workforce is APPs, they should be represented in our medical staff. They should be voting members. They should be on our committees. They should be helping to shape and guide the organization. I will say I've worked in another organization where there was great resistance to this. There was a historical feeling that the medical staff was governed and run by the physicians and that the physicians could speak for the APPs. And the thing that I routinely observed, which if that's a scenario that listeners find themselves in, might help you build a bit of a sense of urgency, is that we had a very unstable APP workforce because our APPs, I think, came to the organization, they were excited about the clinical care, and then came to feel over time that their voice was not represented at the table. And many of them had opportunities to go work for other organizations where their voice was represented at the table. And so if you care about workforce stability, and I think we all should, representation in the governance structure is really important.
That's all the time we have for questions today. In closing, please note that our next Winning Edge program on September 23 will cover the Winning Edge for overcoming key barriers to virtual nursing adoption. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage on handling the APP boom by visiting our website, healthleadersmedia.com.